maybe introduce yourself or something, and that'll fill up the time or something.
Just pause.
Yeah.
Good morning, everyone. My name is Dr. Haj. I'm a faculty here at Widener University. I teach in the undergraduate program. I'm also, and I practice as a nurse practitioner in the area of preventive cardiology. I specialize in lipid management. Today, I would like to discuss several topics under the umbrella of cardiovascular prevention. So I will definitely talk about the most recent ACC/AHA guidelines and the National Lipid Association guidelines, which really guide how we practice in prevention in general. We'll definitely compare the two and then talk about how, as clinicians, we use these two recommendations from the two different organizations. I'll talk a little bit about statins and non-statin agents, especially the ezetimibe Zetia, and the new agent, the PCSK9 inhibitors. Besides that, I will talk about high triglyceride and management of high triglycerides. And finally, I will address the concept of imaging for subclinical atherosclerosis and really how we get to use it in our prevention clinic. So these are the learning objectives for a portion of the of this lecture. I'm going to start with this very impressive survey that was done by the National Health and Nutrition Examination Survey, dates between 2007 and 2010. This is impressive because if you see the individuals range 20 to 39, they still have evidence of cardiovascular disease, whether men or women, in the range of 10 to 12%. So, and here we're not necessarily talking about clinical ASCVD, atherosclerotic cardiovascular disease, but we're talking about evidence of having cardiovascular disease, which could be present as early as 20 years of age and maybe prior. And one thing I tell my patients in the clinic, that the process of atherosclerosis is definitely not an overnight process. It takes decades for the very first evidence of subclinical atherosclerosis to show up on the imaging studies, which we'll talk a little bit about it later on today. But I tell my patients as well that atherosclerosis starts and could start from childhood. And really this depends on the various risk factors, mainly the genetics that we might, carry, of course, from any of our parents. So it's a process that doesn't go overnight. It is not that suddenly someone is having a heart attack. Oh, I've been healthy all my life and I have a perfect cholesterol. And why I have a heart attack? Well, it's a process that takes decades, and there is a hidden process that if we do not unravel early on in life, could be really lead us to events in the future. And this is, again, a very interesting slide that basically summarizes how even if you are treated with a statin, you are still dealing with a good amount of residual ASCVD risk. So, and I've noticed with this slide, we're missing, of course, a very important statin, rosuvastatin or Crestor, but regardless, Crestor is not going to add much more than this. I'll talk about it very briefly after I discuss these trials. So these are trials that included simvastatin, pravastatin, and if you notice, probably at very different dosages, atorvastatin at different dosages, because you do see the event reduction in these major statin trials. So statin reduces LDL cholesterol anywhere between 15 to 50%. So 50%, that's Crestor, close to 50% at least. So you notice the 15% reduction in LDL cholesterol. That is equivalent to 15% reduction in cardiovascular events. And that is very important. So it's the same thing applies, simvastatin, pravastatin, atorvastatin, and I could add Crestor. They all agree that the percentage of LDL cholesterol lowering, it is kind of equivalent to the percentage of event reduction. But it is not enough. We are still dealing with good amount of residual risk that should be addressed and optimized. And that means we have to consider using possibly optimizing further by using a non-statin agent such as ezetimibe or Zetia, or even PCSK9 inhibitors, which we'll be discussing in a little bit, in certain specific cases. I would like again to talk very briefly about the concept of non-HDL. So we know that the main target of therapy is LDL cholesterol. What guides and bring on atherosclerosis in many cases is the LDL cholesterol. It's the one responsible to be sticking at the vessel wall, becoming soft, unstable, stable plaque, whatever it is, eventually could be increasing the risk of events. However, when we are dealing with individuals who have metabolic syndrome, diabetes, pre-diabetes, obesity, who tend to have very high or even high triglycerides, we need to address the concept of non-HDL cholesterol. So what it is, non-HDL is the amount of atherogenic lipoprotein that does not include HDL. So if we look here in this, we start with the chylomicron remnant. So when we are ingesting the fat, first stage is the chylomicron, the biggest one. It's mainly composed of triglycerides, has ApoB48 attached to it. With enzymatic activity, LPL and etc., triglyceride is stripped off, becomes smaller, and picks up a little bit more cholesterol. Now we have main ApoB attached to it, ApoB100. A little bit more cholesterol, less triglyceride, a lower size lipoprotein, that's very low density lipoprotein. Then again, more enzymatic activity gets broken down even for smaller. You have much less triglyceride, much more cholesterol, that's IDL, another atherogenic lipoprotein. And finally, with more enzymatic activity, you are picking up much more cholesterol and much less triglyceride and end up with LDL cholesterol. Well, that is not the case when you have high triglyceride, because you could be dealing with much more IDL and VLDL in the bloodstream, which both are highly atherogenic. So when we are discussing a case or seeing a patient in the clinic who happens to have high cholesterol or high triglycerides, then look at the non-HDL and try to look at the sum of the atherogenic lipoprotein. LDL does not always tell us about the risk. In this case, non-HDL tells us about the risk. One major thing that you're going to see in the clinic when you start practicing is the lack of adherence to lipid-lowering therapy. I cannot stress enough, I have seen so many patients who they get maybe different, they read maybe a lot on the internet, they hear so many things online, or on the media, all the negative news about the lipid-lowering therapy, mainly the statin. They're just scared from statins. So we talk and advise, but at the end of the day, a lot of them are very afraid to get started on the statin, regardless what you tell them about the risk and benefits of this medication. No matter how much I stress the safety profile of statin, there's still this issue of primary non-adherence, meaning patients never fill the statin prescription, and you could have issue with secondary non-adherence, not refilling the statin prescription. So, and that's the importance, and that's why the ACC/AHA did put in their recommendation to really follow adherence. They didn't just say prescribe the medication and never follow up with the patient. They definitely said you recommend the statin and you are expected to check for adherence and look for response on therapy. So I'm going to start with Lucy. He is a 49-year-old male, has a prior percutaneous coronary intervention with a drug-eluting stent to the mid-LAD at the age of 45. So looking at this gentleman, of course, premature coronary artery disease, having had a stent, meaning he has a clinical ASCVD, clinical atherosclerotic cardiovascular disease, as described in the ACC/AHA guidelines. He has a history of smoking. He did quit 4 years ago. He has a body mass index that is consistent with overweight, a BMI of 30, sedentary lifestyle, which doesn't help. Doesn't seem like an optimal blood pressure control, 140/90 on lisinopril, 10 milligram per day. His dyslipidemia is treated with pravastatin, 40 milligram per day. He has diabetes that is treated with metformin, 1,000 milligram per day. So if it was a live lecture, I would have definitely not commented the way I'm commenting, but unfortunately, I'm not able to present this lecture live due to other engagements. So we will talk about his regimen, but let us review now his laboratory values. His total cholesterol is 187, triglyceride of 285, so it is definitely suboptimal triglyceride level. Optimal being less than 150, or acceptable less than 150. For me, optimal should be less than 100, and there are data that supports having less than 100 could be more of a protection for the individual. Definitely a very low HDL cholesterol. In his case, could be a combination of many factors. In his case, could be the sedentary lifestyle, definitely genetics, very possibly tied to having a high triglycerides. So the way I talk to my patients when they have an HDL cholesterol, I completely understand its genetics, and we could do so much to increasing the level. Some medication exists to increase it, but there is no proof of any benefit as a result of raising it. However, I'd like to consider the fact that he has high triglycerides in this case. High triglyceride could be the cause of this HDL being lower than his possible baseline. And the reason why, because having high triglycerides activates an enzyme. There will be what we call a cholesterol exchange between the HDL and the triglyceride. So the cholesterol gets out of the HDL lipoprotein. The HDL ends up getting smaller in size and getting it flushed through the kidney, which lead to lower HDL. And many times, if we ask the patient to work on lifestyle, work on the carbohydrates, and we'll talk about triglyceride in a little bit. Get this triglyceride under excellent control. There is a chance I could get the HDL higher. And the LDL cholesterol of 82, and look at this non-HDL cholesterol. It is amazingly elevated. We are dealing with tons of atherogenic lipoproteins, all as a result of the triglycerides being elevated. So I am thinking not only that he has an LDL cholesterol that could be suboptimal, but of course he has good amount of atherogenic lipoproteins such as IGL, VLDL going in there. He has a fasting blood sugar of 137 and A1C of 7.2. So what change in therapy would be appropriate as we recommended by the 2013 ACC-AHA cholesterol guidelines? So, do we add omega-3 fish oil to lower the triglycerides? Do we add niacin to lower LDL cholesterol and triglycerides? No need for any changes given LDL cholesterol at goal or less than 100 milligram per deciliter, or switch to a high-intensity statin. So that brings us to the guidelines and talking about the guidelines which will help answer this question here. So to start with, the 2013 ACC-AHA cholesterol guidelines were a little bit controversial. The good thing is that they really relied on high level of evidence. So they only wanted to bring forward recommendation based on high level of evidence. That's level 1, meta-analysis of the RCTs, level 2 being RCTs. They were not willing to look at anything lower than level 1 and level 2 to bring in the recommendation. But the controversial thing here was that they did not put in the treatment target for the LDL cholesterol or non-HDL or HDL or triglyceride. They did specify for statin benefit group, and they definitely encourage clinicians to assess the response to the therapy and make sure the patients are adherent to the prescribed therapy. And they recommended as well consider additional therapy in case of residual risk, but no guidance on how to do it. And of course, they leave it up to the clinicians to see if there is any residual therapy risk, of course, or maybe looking for subclinical atherosclerosis. They really did not specify how to do it, but they said consider looking at residual risk. So the 4 statin benefit groups, they identified the high individuals who would qualify for high-intensity statins. So that's at the end of this lecture, I have a slide that showed the high-intensity statins. So that's mainly Crestor 2040, atorvastatin 4080, and so forth. So the high-intensity statin group would be individuals who have clinical ASCVD, like the patient, like the case of Lucy, an LDL cholesterol of greater than 190 milligram per deciliter. And I want to stop and talk about this criteria and why they put in separate category, which is the LDL cholesterol greater than 190, regardless of age. If you notice, the third bulletin point was age of 40 to 75, they have diabetes, LDL cholesterol of 70 to 189, no clinical ASCVD, but has a risk factor, or excuse me, a 10-year risk, the ASCVD pool risk calculator greater or equal than 7.5%. But going back to the second bullet point, which is the LDL cholesterol greater than 190. So these individuals are definitely deserve a high intensity statin because they are most likely have what we call familial hypercholesterolemia. And familial hypercholesterolemia is a genetic disorder that deals with defect in the LDL receptor, most likely, and not having enough LDL receptor to pick up more LDL and decytose them, you are left with very high amount of LDL cholesterol in the range of 200 to 300 if it's heterozygous familial hypercholesterolemia. But the problem with these individuals is that if they have this condition, they could start building up plaque and atherosclerosis very early on in age, and they might end up with a heart attack as early as 20 or 30 years of age. I have a patient who he's 36 or 37, and a couple months ago had coronary artery bypass graft cabbage, and he definitely has homozygous FH. So that's why they did not put an age for next to this bullet point, because no matter what the age, if you have an LDL cholesterol greater than 190, you could have what we call familial hypercholesterolemia. Then we move to the moderate intensity statin group. And this is the individuals who are 40 to 75. They do have diabetes, so they have what we call CAD risk equivalent. They have an LDL cholesterol in the range of 70 to 189, but they do not have a 10-year risk that is greater than 7.5, but less than 7.5%. So they're not high risk based on the calculator, but they do have diabetes, which definitely a risk factor for heart disease. So they do qualify for statin, but not necessarily high intensity statin, but moderate intensity statin. So that means Crestor 510 or atorvastatin 1020, etc. So following the, I'm not sure if we're going to talk about the case again, we might, but if I want to do something for the case of Lucy and looking at the ACC/AHA guidelines, he has clinical ASCVD. He should have on board high intensity statin, and our patient was not managed with high intensity statin, was managed with a moderate intensity statin. So I would definitely intensify the statin therapy. So another question in this case, following the 2014 National Lipid Association recommendations for patient-centered management of dyslipidemia, what should be Lucy's optimal goal? So here's what happened historically when the 2013 guidelines were released. The National Lipid Association, which is another prestigious association that kind of a lot of clinicians follow to guide that to help manage our patients, they were not happy with those guidelines. They were not happy that the ACC/AHA did not really put what we call a goal for an LDL cholesterol, for example. They said, let them be on a high intensity statin, there's no treatment goal whatsoever for the LDL. So the National Lipid Association, they released their own recommendation and they insisted that the lower the better, and we definitely insist that we should get this LDL cholesterol less than 70 for individuals who are considered high and very high risk, or at least very high risk, which is the clinical ASCVD. So in the case of Lucy, who is considered very high risk under the National Lipid Association guideline, he should be treated with a goal LDL cholesterol level of less than 70 milligrams per deciliter. So here is the NLA ASCVD risk category criteria. They have 4 different categories. One that is a very high risk, so the case of Lucy, ASCVD, has a type diabetes mellitus, greater or equal than 2 other major ASCVD risk factors. High risk, having greater than 3 major ASCVD risk factors, diabetes type 1 or 2, CKD, or LDL cholesterol greater than 190, moderate, 2 major ASCVD risk factor, and low 0 to 1 major ASCVD risk factors, and the other recommendations are there for you to read. So this is, they continued and they did specify targets. So for those who are considered very high risk, you definitely need to consider drug therapy with the goal of reaching an LDL cholesterol less than 70. For high, moderate, and low, they were okay to get an LDL cholesterol less than 100. This is an overview of dyslipidemia management strategies. So the number one thing I say to patients, and that is the number one thing that's in all the guidelines, is heart-healthy lifestyle. So there is nothing should trump heart-healthy lifetime recommendation, heart-healthy lifestyle recommendations. And if you notice, that's a bullet number 1 in every recommendation. So I tell my patients, I am not going to recommend statin and statin should not be replacing you doing changes in your lifestyle. So that means exercising, aerobic activities, 30 minutes most of the week or 5 times a week. That's 150 minutes of aerobic activities. Heart healthy lifestyle, weight loss if needed, for a BMI anywhere between 19 to 24, smoking cessation if they were smoking, and definitely optimal control of their blood pressure and diabetes if they were present. For primary prevention and those who are at lower ASCVD risk, we could consider imaging for subclinical atherosclerosis, looking at biomarkers such as CRP, considering family history, etc. Start statin following the NLA and ACC/AHA guidelines. We talked about it. Of course, monitor response therapy, and when the level remains suboptimal, depending on the risk. So for someone very high risk for NLA or high risk for ACC, and I have an LDL cholesterol 90, and I want to possibly increase the potency if it's not already at the max, or add a non-statin agent, such as Zetia, and in some cases, PCSK9 inhibitors. So, we talk about LDL-C being a target, or most of the time a target of therapy. We talk about statin and its ability to lower LDL cholesterol. However, achieving that goal still remains a challenge. To the right of the screen, this is a retrospective data from the VA hospital network. Left of the screen, a retrospective data on 9,000 individuals from a large cardiology practice. And you look at this, statin alone, as expected, is going to lower the LDL cholesterol, but only 37% of people are at goal of LDL cholesterol less than 70. You add niacin to it, of course, niacin is going to decrease the LDL cholesterol by an additional maybe 20%. And yeah, that increases the amount of people who are at goal to 46%, but you still have around 50% of people not at goal. Statin and ezetimibe, we know Zetia decreases LDL cholesterol by 10 to 20%. So yes, it increases a little bit than statin alone, but again, not enough. Statin and fibrate, just to let you know, fibrate, we do not use it for LDL lowering. Statin and fibrate, honestly, fibrate should not be used unless someone has a high triglyceride. It has been studied. There is no cardiovascular benefit when using fibrate for lowering LDL cholesterol. So I would not recommend. This combination would definitely increase the risk of having myalgia and other side effects that I would not recommend. So this slide clearly show that a lot of our patients are not at goal despite being on statin therapy. And this is our study in our health system. This is a paper I'm going to present at ENURS, Eastern Nursing Research Society this spring time, that showed that our data is very similar to the national data. And that is the University of Pennsylvania health system. And we looked at individuals following ACC, at goal with ACC/AHA guidelines, at goal with NLA or either. UPHS as a whole, we were 40% at goal. Cardiology a little bit better. Our group prevention, of course, we got better scores, but still, either guidelines, we're still at 60%, 40% are still not at target with the guidelines, do not meet target. It's a problem. When we audited our charts, a lot of them, patients were not able to tolerate the statin, or they did not believe that they should be on a statin, or they were afraid from using statin. So to go back to that slide that I showed, that shows that a lot of people, or a good amount of individuals, will not buy the being on therapy for statin. So LDL cholesterol less than 70 definitely is difficult to achieve, even with high dose statin, but we know the lower events happens if we were able to get that LDL cholesterol less than 70, and optimally, I say to my patients, 50, especially those patients who have heart attack, MI, ASCVD, stents, all that. Those individuals are very high risk. My goal for them is an LDL cholesterol 50. And one thing I would like to keep in mind, again, that's a teaching point for your patients. Every 1% lowering of your LDL cholesterol is equivalent to a 1% lowering of cardiovascular event. So when we say statin drops LDL cholesterol by 40%, that is equivalent to 40% risk reduction. Here is a summary of the hazard ratio. What percent reduction in events you're able to achieve if you get an LDL cholesterol anywhere between 75 to less than 100, 50 to less than 75, and less than 50 milligram per deciliter. So the first group has a hazard ratio of 0.56%, meaning we're able to lower their event rate by 40%, compared to less than 50, which drops the hazard ratio from 0.56 to 0.44, so close to 60% lowering. That means that change from 75 to less than 50 would add an additional 17 to 19% lowering of events. We're able to drop it by 20 milligrams per deciliter. So then that's major, and I go by data from evidence-based trials. I go by these data just to convince my patients that lower is better, and at their level, greater than 70, they're not being optimized. So I have another case here for you, a case that I called it to add or not to add. This is a patient, 62, female, has a history of MI, so that means she has clinical ASCVD. She had a non-treated LDL cholesterol of 184 that was decreased to 98 milligram per deciliter on Crestor 40. So she is pretty much following the ACC-AHA guidelines. She's on high intensity statin. We dropped her to less than 100. If we look at the NLA guidelines, no, that is not enough. We need to get this LDL cholesterol to less than 70. LP little a of 235. So LP little a is a genetic marker of heart disease. So what it is a little a, something like an ApoB that sits on the lipoprotein. It's a little a that sits on the LDL. When it is above 3 times the upper level of normal, so here the upper level of normal is less than 75, and in this case, this patient has an LP little a of greater than 3 times the upper level of normal. They are at high risk to develop DVTs, aortic stenosis, high risk for events. So they are high risk in general, stroke, mini stroke, and things like that. So I'm not going to delve into a lot of details. There is a lot of information I could talk about, but that's not the purpose of today's lecture. But in all cases, she's high risk. Which of the following are reasonable options in this case? Add fenofibrate, add the PCSK9 inhibitor, add niaspan, add ZA or ezetimibe, or reassure patient that risk has been optimized. Well, in my clinic, a patient like this, with an LDL cholesterol of 98, even on high-intensity statin, this patient is not optimized. So in my clinic, E will not be the case. I would want to discuss adding something else on top of Crestor, in this case, a non-statin agent. A, add fenofibrate. Never do that for LDL lowering because we have clinical trials that showed no benefit adding fenofibrate, no cardiovascular benefits by any means if you add fenofibrate. We restrict fenofibrate for high triglycerides. What's left is B, C, and D. Add ZDL, add niacin, add PCSK9 inhibitor. Adding PCSK9 inhibitor would be a reasonable option if our patient was on ZDL. because of the requirements from being on these two agents by the insurance mainly before adding on the PCSK9 inhibitors. I'll talk about it in a little bit. And niacin will be an option if your patient was on a proven medication such as Zetia. So niacin, a couple trials have been done on them. And unfortunately, although niacin has a lot of chance to be a very valuable medication, but did not show in clinical trials that it's able to lower cardiovascular risk events. Niacin, I do it in my clinic after Zetia for strictly LDL lowering, keeping in mind that by lowering the LDL, I'm helping the patients, but I only do it after I use proven medications such as Zetia. So the next proven medication to lower cardiovascular events is Zetia. So after I maximize my patient on statin, the next agent to use is Zetia. And the next slides, we'll talk about the improved trials that was done to show the benefit of Zetia. So the patients in the improved trial were post-ACS patients. They had an LDL cholesterol anywhere between the range of 50 to 125. Good amount of individuals were enrolled. The goal was to see if we add Zetia on top of a statin, does it give you any benefit? Does it lower cardiovascular events, and by how much? To remind you, ezetimibe blocks sterols in the intestine and lower LDL cholesterol by 10 to 20%. So automatically, if you think about it, it is not going to give you a lot of change, a lot of decrease in cardiovascular event, but it might give you some. And that is the purpose. We're not looking for a great effect, but we're looking to see if it gives any added benefit on top of statin. So it was estimated 2.5 years, but of course it took much longer because of the small effect, I'm guessing. And it took a total of 6 years to get the results of the improved trial. So as I mentioned, 18,000 were enrolled. The graph on the left is basically the LDL cholesterol, the red being Zetia alone, simvastatin alone. So the mean LDL cholesterol on simvastatin alone was 69.5 milligram per deciliter. Adding simvastatin to Zetia, and as I mentioned, lowering anywhere between 10 to 20%, as expected, dropped it to 50.7 milligram per deciliter. That was equivalent to around 7 to 8% lowering of event rate. So that's a hazard ratio of 0.9. As expected, I didn't expect much more, but it is statistically significant. The number needed to treat here was 50. So every time, for every 50 individuals you treat with Zetia, along with simvastatin or other statin, you're able to save one event. So in summary, I'm not going to go over that. Statin, you all know the way it works, upregulate LDL receptor by getting rid of the LDL through endocytosis. Zetia inhibits sterol absorption, bile acid sequestration like Welchol, binds cholesterol at the gut level and promotes cholesterol excretion. The niacin, PCSK9, we'll talk about it in a moment. So the next slides, I'm going to go over the PCSK9 inhibitors. But before I talk about it, I'd like to go over how do we get rid of LDL cholesterol. What is the process? We all know that the LDL receptors that sits on top of the liver cells are mainly responsible to clear LDL cholesterol. Here is how it works. So you have, this is the hepatocyte, this is the LDL cholesterol, this is the LDL receptor, this is the LDL cholesterol. Of course, what happens here, an LDL cholesterol sits on top of the LDL receptor, goes inside the liver and into endocytosis. And what happened in a normal situation, the LDL receptor gets separated, cleaved from the LDL cholesterol. LDL receptor go back to the liver cell. In a normal situation, this LDL receptor gets recycled up to 150 times. This is killed by endocytosis. LDL receptor go back to the liver cells, 150 times able to recycle itself to pick up more LDL. That is when LDL receptor is left alone. And that's what happened. Around early 2000, an enzyme called proprotein convertase subtilis and type 9 was discovered. And what they noticed, that this PCSK9 was kind of binding and attached to the LDL receptor. And when it attached to the LDL receptor, as soon as the LDL receptor is picking up an LDL, both of them are being degraded. The LDL receptor did not get the chance to go back to the liver cell to get recycled 150 times it's usually done. So here is what happened in individuals. In this side, we're looking at the gain of function mutation of PCSK9, meaning you have a lot of PCSK9 in the bloodstream, and on top of liver cells. And here are individuals who have loss of function mutation of PCSK9. They do not have PCSK9 enzymes, and let us see what happens. So here you have a lot of PCSK9 that leads to LDL receptor getting rid of LDL receptor, and the LDL, you have much more LDL sitting in the bloodstream, in the, on top of liver cell. Nothing is being done with them because you do not have enough LDL receptor there. On this side, an individual has loss of function mutation. You do not have PCSK9 enzymes. You have much more LDL receptors because these LDL receptors are functioning normally. They are not attached to any PCSK9 enzymes. They are not being degraded in here. They are going back and picking up more LDL. So you see the difference. Much more LDL when you have PCSK9 enzymes floating, much less LDL when you have PCSK9 not floating around much. And here is what happened with PCSK9 inhibitors. So the PCSK9 inhibitor is a monoclonal antibody. It's a fully human. It is not from mouse. Fully human monoclonal antibody that gets attached to PCSK9 enzyme. So an antibody that goes and sits next to the enzyme, leaving LDL, more LDL receptor on top of liver cells and less LDL in the bloodstream. So here is what happened. You have PCSK9 enzyme, you have less LDL receptor, you have more LDL. You have the monoclonal antibody, that is Praluent or Repatha, sitting and attaching to the PCSK9 enzyme. You have much more LDL receptors and much less LDL cholesterol. So very neat how it was discovered and how it was created and really how it works beautifully. The next couple slides, we'll talk about the clinical trials done on the two products, Praluent or alirocumab and Repatha or evolocumab. Here is the first trial called Combo 2. And that's Praluent alirocumab was against or given either alirocumab or Zetia with added to max tolerated statin. So we're starting here, ezetimibe with a placebo, and max tolerated statin in high cardiovascular risk patients. So all the patients who were recruited were patients who had heart attacks, stents, things like that. So you have the ezetimibe in the gray plus the placebo. The LDL cholesterol was 82.5, and you have alirocumab plus placebo ezetimibe that dropped the LDL cholesterol by good 50%, 82 to 51. The other agents, evolocumab, GOS2, here, they used evolocumab on statin intolerant patients. So patients who absolutely cannot take statin. In the gray, we have ezetimibe. In the red, we have evolocumab, 140 milligram and 420 milligrams. The difference, again, was an additional 50% lowering. For some reason, the 140 gave a little bit more lowering than 420. So the way it is used, if you decide to give the 420 milligram, it's a once a month injection. This is a twice a week injection. We'll talk about it in a moment. And here is the event reduction within the clinical trials themselves. So when we talk about this medication right now, as we stand to patients, we cannot talk about outcome trials because outcome trials are still in process. We will hear back preliminary outcome trials sometime next year or the year before after, 2018, 2019. What we can talk about are the event reduction or outcomes within the clinical trials themselves. So we have Osler and Odyssey. Alirocumab was Odyssey, evolocumab was Osler, and an amazing reduction. Hazard ratio of 0.52 versus 0.47, both statistically significant. So that means, in other words, both agents were able to lower cardiovascular event by an additional 50% compared to standard therapy, which would be statin plus Zetia or Zetia alone if statin intolerant patients. So amazing reduction, amazing splitting of the curves, very promising medication. So adverse events, we all know the problem that really took place with statins. 10% of people had muscle aches. Much definitely rare was rhabdomyolysis. Again, we see myalgia being reported here, but what I can tell my patient, much, much, much less occurrences. So 5% versus 2.9%. Honestly, I don't look at it as if it is clinically significant, although I have to report it to my patient, but it is statistically significant. Another common thing that took place was flu-like symptoms, that another occurrence. Overall, what I tell my patient, this is a very safe medication. I don't have to worry about drug-to-drug interaction. I do not have to worry about its effect on the liver, kidney, or any of that. So pretty safe medication. And this is a summary of both. They were both FDA approved in 2015, month apart, July and August. The indication, very important, because we cannot use it on anyone. At this point, it's only approved for individuals who has FH, heterozygous FH mainly. It's not contraindicated for homozygous FH. However, they might not react or have the LDL reduction the way others would have, because individuals with homozygous familial hypercholesterolemia might not have LDL receptors and might not respond well to the two agents, any of the two agents. But heterozygous FH, meaning they carry one gene from one of their parents, might have some LDL receptors, and the PCSK9 inhibitors might work on them. So individuals should have FH, familial hypercholesterolemia, ASCVD, did not get to an LDL cholesterol less than 70 if they have an ASCVD, on top of both statin and Zetia. They can be prescribed this medication. I can tell you it's a lot of insurance problem dealing with it, because many of our patients are statin intolerant, and we have to show and prove and appeal in many situations the fact that they are statin intolerant. So insurance want to see that they are on statin and Zetia before they approve this expensive drug of PCSK9 inhibitor. So it costs around $1,000 a month. But it's covered by insurance. Problem with Medicare, Medicare patients tend to have a lot of copay and they might get into the donut hole very quickly. That's why a lot of my patients who are on Medicare kind of turn down this therapy even after they were approved. Okay, so the side effect, as I mentioned, is nasopharyngitis was one of them, hypersensitive reaction, but again, nothing that was significant and no major side effect from the two. Okay, so if you remember correctly when we talked about the 2013 ACC/AHA recommendations, they did not specify target for LDL cholesterol. Well, they kind of looked at all the comments they received from the different organizations and clinicians, and they brought a new adapted version statement. It's called 2016 ACC Consensus Statement on the Role of Non-Statin Therapies for LDL-C Lowering. So basically, they identified the two high-risk categories, the ASCVD and the FH, familial hypercholesterolemia. And they said, for those who have ASCVD on max tolerated statin, you could choose to add Zetia if LDL cholesterol is greater than 70, and add PCSK9 inhibitor if LDL cholesterol greater than 70. We kind of changed their stance a little bit and kind of added targets to therapy. FH, very similar, but they increased the target to LDL cholesterol greater than 100 versus greater than 70, because they're not as high risk, of course, as the ASCVD patients. Using Praluent, I mean, that's one of two. I do not have any preference in between the two, honestly. Both of them work similarly. They're both fully human antibodies, monoclonal antibodies, so no difference. I only order randomly, and sometimes they tell me their insurance will not take what you order, change it, I change it. Praluent, when the patient receives it, they need to store it in the refrigerator. What's recommended, they should get it out of the refrigerator and let it warm on room temperature 30 to 40 minutes before use. For Praluent, once you get it out of the refrigerator, you cannot put it back. And it only lasts for 24 hours. So they have to use it within 24 hours. That is a little bit different than Repatha, which once they get it out of the refrigerator can be in their pocket for a month, which is an advantage. Especially for those patients who travel a lot. So I do ask the question sometimes if we travel a lot and I order Repatha instead, but sometimes I'm stuck with the insurance preference. It's a subcutaneous injection. It's like an EpiPen, very easy to use once every 2 weeks. Now, we finished from talking about the guidelines and the PCSK9 inhibitors. Now let us talk about high triglycerides, the case-based approach. So I'm going to present you several cases from our clinic and talk a little bit about how we approach every case. Every case is different. So when we treat triglycerides, triglyceride is a type of fat. It definitely increases the risk of cardiovascular disease and cardiovascular events if left untreated. Number one, we need to reduce cardiac risk. Number two, if the triglyceride is very elevated, my priority is to avoid pancreatitis and drop the triglyceride first before dealing with anything else. Number three, we have to consider the etiology of the high triglycerides being commonly related to metabolic syndrome. And number four, we need to manage side effects. So here is case number one, case of metabolic syndrome. This is a 50-year-old female. She is obese, BMI of 32. Hypertension, suboptimal, 140/90. We don't know anything else about her. Lab results, total cholesterol of 235, triglyceride of 258, LDL cholesterol of 133, and an HDL of 50. What do you do during this visit? Do you add the fish oil? Do you add the fibrate? Do you add a statin? Do you order additional labs, or do you reassure the patient? So this is how I look at a case in my clinic. This is an individual who has several risk factors of what we know about. She is obese, she has hypertension, she has high triglycerides. I don't know about the LDL cholesterol because I do not know her risk 100%, but I'm thinking her LDL cholesterol could be high. So what do we do? Fish oil and fibrate are fine. You can do that. They would lower the triglycerides. But honestly, what's happening here could be fixed by lifestyle. So when your triglyceride is under an okay control, it's not super elevated where I have to worry about pancreatitis. When it's in that range, less than 500, I can sit down and counsel the patient on the importance of exercise, importance of diet. That diet has to be low carb diet, and importance of weight loss. I can assure you, and I do assure her, that if she works really seriously on exercising, diet, and losing weight, I can reverse this triglyceride to a very optimal level without adding any medication. So I'll definitely counsel on lifestyle first. I do not need at this point to add fish oil and fibrate because I need to give her a chance to exercise. Number 3 is one thing I need to think about. I need to consider adding a statin after I know a little bit more about her. And in this case, I will order additional labs. One thing I want you to know about metabolic syndrome, we deal with a lot of residual risk. And what you see on a cholesterol profile is not always the correct number. So when you see an LDL cholesterol of 133, this does not mean her real LDL cholesterol is 133. I'll talk a little bit in the next slide. So it's important that we treat triglycerides. Priority when triglycerides are over 500, there is a risk of pancreatitis. So I am not going to think of cardiovascular risk and adding a statin and any. I want to decrease it to a safe level. I want to make sure to avoid pancreatitis, okay? And triglycerides are secondary when under 500. And that's what I mentioned in the case earlier. They're less than 500, not a risk for pancreatitis. I can talk about prevention. I can talk about risk assessment. I can do a lot of things. I have room to give her some more time and work on lifestyle and come back with another lab result or order more advanced fancy lipid testing to understand better her cholesterol. And to go back to the non-HDL, because I really need to look at atherogenic lipoprotein. Any time triglyceride is greater than 200, please look at the non-HDL numbers. Now, this is a very interesting graph here. Looking at event rate, if your triglyceride is above 150 or less than 150 after so many days of being in that level. So in the red, your triglyceride is above 150. In the blue, your triglyceride is less than 150. Look at how the curve split. You have a hazard ratio of 0.73. You are able to lower the risk of events by around 30% if your triglyceride is less than 150 for an extended period of time. So that is another thing that to consider the importance of treating triglyceride. It's associated with increasing cardiovascular risk and events. So here we go. So let us go back to our case. She's obese, hypertensive. We have we already reviewed her lab values. We calculated her risk. So we know the guidelines recommend that we do the ASCVD pooled cohort risk calculator. And if it's less than 7.5%, you do not need to treat with a statin. But they do recommend to do further testing if necessary especially if they're low risk and if you want to find out more about the risk. So what do we have here? We're dealing with a metabolic syndrome. This patient has everything, all the 5 components of metabolic syndrome. She's obese. She's hypertensive. Well, actually, she has an HDL of 50, so she's good. Triglyceride, that's elevated. Glucose, that's elevated. She has at least 4 out of 5. She has metabolic syndrome. Anytime you have at least 3, you have metabolic syndrome. Now, you have metabolic syndrome, think of looking beyond a regular lipid profile. And I'm not sure if you were ever exposed to the concept of LDL particle, but what really contribute to atherosclerosis, or the process of plaque buildup in the vessel wall, is not the LDL cholesterol. What we are checking in regular lipid profile is the cholesterol content in the lipoprotein, the LDL. But what determines, assuming that LDL is exactly as LDLP, but what determines atherosclerosis is the amount of LDL and not the cholesterol content. In general, without metabolic syndrome, for individuals who just have high cholesterol, we assume that this LDL cholesterol on regular lipid profile is exactly the same as an LDL particle. So an LDL cholesterol of 130, for example, is equivalent to an LDL particle of 1300. The way you calculate it, you chop the last digit, and you're left with the LDL cholesterol number. But that's not the case in metabolic syndrome. You could be dealing with low-dense, small-sized LDL instead of a large buoyant LDL, and you could be dealing with a big discrepancy between the LDL cholesterol and LDL particle. And I'll talk in the next slides, we're going to tell you what this patient's LDL particles were after we checked an advanced lipid testing. That's basically summarize that slide. So, knowing, thinking that there could be a discrepancy between the LDL cholesterol and her real LDL being LDL particles, I checked advanced lipid testing. You could go to Quest and ask for lipoprotein fractionation. And you could go to LabCorp, and in this case, you order what we call NMR, nuclear magnetic resonance. In this case, I got an NMR. LDL particle was 1700, so her real LDL was 170, was not 130. AHCRP was high, 10.8. She has a lot of inflammation going on. This individual is high risk. She meets the criteria to be on statin and initiated statin. There's another case. There's another case for diet. What diet would you put on a patient who has this triglyceride on the left versus this triglyceride on the right? 43-year-old who has this profile, total cholesterol 419, 2688 triglyceride, 22 in HDL and 49 for direct LDL. This triglyceride, well, first, high risk of pancreatitis, but besides that, this triglyceride is genetic. It's what we call familial hypertriglyceridemia, and it's chylomicron driven. So there is, basically, we are sticking at the chylomicron level. There is no, possibly this individual lack of the enzymes that break down the chylomicron into the smaller VLDL, IDL, and then LDL. So that said, this diet should be a very low-fat diet. When the triglyceride exceeds the 1,000, think of chylomicron-driven triglycerides, and you advise very low-fat diet. The one on the right, the 46-year-old, you have a total of 230, triglyceride of 320. This is a carb-driven diet, triglyceride. You advise very low-carb diet. Very different diet regimen depending on the triglyceride levels. So, very important. I cannot stress enough the importance of lifestyle modification and diet advice. We talked about the carb restriction for the triglycerides and the fat restriction for the severely elevated triglyceride. So case A, we advise very low fat diet. We prescribed Lovasa 2 tablets BID, and the triglyceride went down from 2688 down to 264. Case B, very low carb diet. Again, we gave the fish oil. Triglyceride went down to 152. Please consider the secondary causes. Ask about drugs they're on. Ask about alcohol, of course, and the carbohydrates. Pharmacologic intervention, what do we do in this case? This is an individual who has CAD diabetes, has a total cholesterol of 280, triglyceride of 1,788, HDL of 16, creatinine of 1.8. His medications, fenofibrate of 54, niacin of 500. He's on Lovasa 3 tablets twice daily, and on Lipitor 40 milligram daily. So, well, first let us talk about the intervention. Fish oil. I recommend when the triglyceride is seriously elevated, patients want to do the over-the-counter fish oil. Over-the-counter fish oil do not have, first, they're not purified fish oil, and they do not have the amount of EPA DHA that the prescribed fish oil would have. So the pros, they're purified, natural, they're definitely effective. They would lower the triglyceride to around in the range of 30%, 30 to 35. Cons, they're blood thinning, they could increase the risk of bleeding, insurance problem, they wouldn't cover it because it's expensive. Hopefully, you know, the recent Vasipa has been in the market for a couple of years now. No, 3 to 4 years maybe. So they're still very expensive. Fenofibrate, an older drug, it comes with side effects. Renal dosing, of course. You have to watch the medications that could have a drug-to-drug interaction. A little bit more efficacious, has more efficacy than the Lovasa or the Vasipa, around 40% reduction. Niacin, another agent that will lower cholesterol, triglycerides, and of course it lowers LDL and increases HDL, but the one main problem is the flushing that happens with it. So a lot of the times we advise patients to take it at night before they go to sleep and to pre-medicate with aspirin. Full dose 325 milligram of aspirin, and a lot of patients tolerate it just fine with the pre-medication and when they take it at night. However, you really have to be careful. You cannot give it when someone has atrial fibrillation, gout, peptic ulcer disease, etc. You have to tell them to avoid spicy food and things like that because of the risk of palpitation and things like that. What do you do when you have elevated LFTs? You have this individual with this profile, has really high triglycerides, HDL of 93. Think of the HDL 93. Don't estimate that he's really protective because HDL is atheroprotective. Think of it. AST of 350, really elevated, ALT of 350. He's on these medication, Atorva 89, 1500. What do you think really caused this elevation? Many things. Atorva, niacin, alcohol, hepatitis C. Well, if you look at the profile, of course he has high triglycerides, really elevated. His HDL is very elevated, or elevated, and elevated AST greater than 3 times the normal. So one thing that I would like you to consider is alcohol and heavy alcohol use, especially when it comes to high HDL. So heavy alcohol use would definitely raise the HDL, and you have to inquire about it. And of course, increases the triglyceride and definitely increase the LFTs. So ask about heavy alcohol use. And so for a lot of my patients always ask me, I'm afraid the statin and its effect on the liver. Well, one thing I answer them is that statin is a very safe medication, and the proof, the FDA released statement several years ago that they do not have to repeat checking LFTs every time they're seeing patient, as long as they determine that the patient has normal LFT. So you determine you have a baseline normal LFT. You're not required to repeat checking LFTs on patients. However, we do that in our clinic. So you want to consider stopping statin if the LFT goes up to 3 times the normal, and you want to consider other stuff along with it. So someone who has a metabolic syndrome, high triglycerides, low HDL, whatever, obese, consider fatty liver. You want to get ultrasound for the liver, you might see fatty liver. But this does not mean that statin is the cause. You want to treat them with the statin, even if the LFTs rise a little bit, as long as it's less than 3 times the normal. And you're going to counsel them on lifestyle. You're going to talk about the fatty liver. You're going to notice with time the LFT elevation might fall. If they work on their lifestyle, get their triglyceride under better control, lose the weight, they might get rid of their fatty liver and have a resolution of their abnormal LFTs. And you're gonna really treat fibrates and the niacin in the same fashion as we talked about the statin. So when I follow up on the case of the triglyceride of 2000, this man was a very heavy alcohol user. So we did tell him to drastically reduce, and he did reduce the alcohol intake to 1 drink per day. He did follow a very low-fat diet. He started taking the Lovasa, and he restarted his statin, and his LFTs normalized. LFTs dropped from 350 down to 44, and down to 46 for the ALT, and his triglycerides with the changes that we asked dropped from 2,071 to 146. Very impressive. Conclusion, I cannot emphasize enough the lifestyle modification, especially for triglycerides that is not necessarily chylomicron driven or familial. Talk about metabolic syndrome in great detail. Sometimes you have to treat prediabetes along with the high triglyceride. Emphasize the low carb diet for the triglyceride that are less than 1,000. Emphasize the low fat diet for severely elevated triglycerides. And these are my conclusions. My the last portion for this lecture is talking about cardiovascular risk reduction beyond statin therapy. And here I'm going to talk about the importance of checking for imaging for subclinical atherosclerosis. So the goal in our clinic, in our prevention clinic, is to improve risk assessment, really try to understand better the risk of every individual, not strictly looking at risk factors or looking at the pooled cohort risk calculator. We treat people based on presumed risk. So to treat or not to treat this individual with a statin. This is a 48-year-old male, has a blood pressure of 108 on medication, has a family history of CAD, he has an HDL of 34, triglyceride elevated 320, LDL of 136, he has sugar of 102, but no other risk factors. Here is what the recommendation from the ACC-AHA. You would have considered high risk if you have a CAD, clinical ASCVD, and less than 75. You need to be on high intensity statin. You need to get a goal of LDL of 70 to 100. And these are the high intensity statin at 40, 80, Crestor 20. Moderate intensity statin for those individuals who are greater than 75 years of age and have ASCVD. You have diabetes and an ASCVD score of less than 7.5, or to have a score greater than 7.5, and these are the recommendations for statin use, and the goal LDL less than 100. But pay attention to here, you're considered low risk if you have a score of less than 7.5. They recommend to look at family history, imaging for subclinical atherosclerosis, look for calcium buildup in the coronaries, check ASCRP, and ABI-PVR. So here's our patient. our patient, that's his the criteria. He is treated for high blood pressure, doesn't have diabetes. We plugged in his numbers, per guidelines, pooled risk calculation. He's at low risk, his 10-year risk score. So per ACC/AHA guideline, this patient does not need to be treated with statin. However, per NLI guideline, remember if you have greater than 3 risk factors, he has 4. He has the glucose being elevated, the LD, the triglyceride being elevated, the HDL being low, and he has a family history. And he has a blood pressure that's being treated. So he has 4 risk factors. NLI recommend to treat, ACC/AHA recommend not to treat. What do we do here? Well, we know that cardiovascular disease is a big problem, and we know that it does not need to have a risk. You do not need to have a risk factors or many risk factors to be at risk. So around 50% of people who comes in to the hospital with CAD present with an MI or death. 50% of people. I mean, that's major. The conventional risk factors we mentioned earlier only explain 50 to 60% of the risk. And then more seriously and more alarmingly, this number, 60% of patients who present with CAD have only 0 to 1 risk factor. I have more slides to show you, very impressive. So class 2 recommendations. Basically, you have an option to check the calcium score and as a way to image for subclinical atherosclerosis. You may treat for an AHCRP greater than 2. You should consider family history of premature disease and ABI less than 1.5. So I want to talk about imaging for subclinical atherosclerosis, and in this case, looking at the calcium score on CAT scan. Look at this slide, very impressive. You have into 18,000 individuals who do not have any risk factor for cardiovascular disease, but we happen to advise them to get a CAT scan. 50% of people had a score. So these are 50% of individuals who do not have any risk factor for heart disease might end up having calcification around the coronary arteries or atherosclerosis or evidence of atherosclerosis. Of course, the number, the number will change as we have more risk factors. But I wanted to focus on this first category: individuals with no risk factors whatsoever. Around 10% might have a score greater than 400, meaning they might have a blockage already in the coronary artery. Another very impressive slide. Here is mortality rate of individuals with 0 risk factor, but having a score. And look at this, compare it with individuals with greater or equal than 3 risk factor, but no score. If you have score and no risk factor, you have a much higher mortality rate than no score and greater than 3 risk factor. So I get someone who build up plaque. He is young, athletic, good cholesterol profile, no blood pressure, no diabetes, very active lifestyle, but family history of premature disease. And I check his score, and he has a score greater than 400. He's at high risk of dying than an individual with diabetes, hypertension, dyslipidemia, sedentary lifestyle, but no score in his CAT scan. Just think about this as you are seeing your patients. So let's go back to our patient. We advise him, he has a bunch of risk factors and he didn't want to go on statin, but I want to convince him somehow to try to understand his risk better. And I told him, you know what? Let us get a CAT scan for your heart and see if you have any plaque. If you do not have any plaque, I can let you go without statin for a couple of years. and he had a score of 173. So of course we initiated statin. This is the same case as before, I believe, but this individual has an MI, LDL cholesterol 496 dropped to 124 on Crestor 20. What do you do in this case? What's reasonable in this case? Of course, I want to get her Crestor to 40 milligram. I want to ask her to take a higher dose, because I know if I get her to 40, I'm lowering her cholesterol by 6%, which is not enough, but I want to maximize on statin before I do anything else. My second would be to add Zetia. So I would bump her up to 40, I'll get 6% lowering, if she can tolerate, of course, 40. And then I will add Zetia, which will give me 10 to 20%. And with the combination of the two, I might get her less than 100. However, I might need to add a PCSK9 inhibitor on top of the two to get her less than 70. And my conclusions, recent studies support the LDL hypothesis. Of course, the lower the better. My patient in the clinic, I shoot with an LDL of 50 if they have ASCVD. Non-statin agents are useful if the patient is far from getting the goal. Zetia is the only proven agent beyond statins. We're waiting for the PCSK9 inhibitor trial. They have great potential. And current use still to be determined. Consider adding to maximally tolerated statin therapy for FH patients with LDL greater than 130, excuse me, and a CAD patient with an LDL greater than 100. So as I mentioned, the lower the better. If I can get them to 50, I'm going to do every effort to get them the lower the better. And what I tell my patients, I want to get your LDL cholesterol to a physiologic level. I want to get it to a level where it's only supposed to do what it's only doing what it's supposed to do at the cellular level, at the cellular metabolism level. And I don't want to give it a chance to be able to stick at any vessel wall if I'm able to, if that is even a case. But I'm going to give it a try, and I'm going to get my patient to buy that plan with me. That concludes this lecture. If you have any questions, please do not hesitate to email me. My email address is J like Joseph, H like Henry, J like Joseph @widener.edu. Thank you for this opportunity, and I look forward to hearing from you anytime. Take care and have a good day.